Good morning, everybody. Thank you for the invitation. For those who don't know me yet, my name is Sven Hillinger. I'm Senior Consultant from the Division of Thoracic Surgery. And it's my pleasure to introduce Valerian Dirr, second-year resident, who will present you the essentials about pneumothorax. Valerian.
Thank you very much for a kind introduction. So I also would like to welcome you to today's residence lecture. The topic is pneumothorax, and I'd like to start with the definition and the anatomy. So pneumothorax is termed as gas in the pleural space, and this space is somewhere between the lung and the chest wall. And starting from the outermost layer of the chest wall, there's skin, superficial fascia, subcutaneous fat tissue, and then there's the respiratory muscles, such as the serratus anterior muscle. In between the ribs, there's the intercostal muscle. On the inferior edge, there's the intercostal bundle, supplying the region with blood and nerves. And there's a really important landmark, the endothoracic fascia, which marks the end of the chest wall and the beginning of the thoracic cavity. As the next layer, there is the parietal pleura. It covers the whole internal surface of the thoracic cavity, and the visceral pleura covers the surface of the lungs. And in between, there's the pleural space. And this space has two major functions. One of them, it contains serous fluid, allowing the two layers to glide over each other. And the other one, it creates surface tension. So when the thorax expands, the lungs are expanding, filling it with air. Today we have different appearances, mostly appear during radiological diagnosis, for example, in a chest X-ray. So we can describe an apical pneumothorax, that means there's only air in the apex region, a mantle pneumothorax where it has a mantle shapes and covers the whole surface of the lung. It can be concomitant with blood or fluid, so a hydro or hemato pneumothorax. And if there's so much air within the pleural space that the lungs are not able to expand, it's considered a total collapse. So we can divide it into a closed one, where there's a bronchopleural fistula, so the air is coming outside of the lungs. And there's an open one where there's a damage to the chest wall, so there's an inflow from outside. And we can describe a tension, which means there's a one-way valve mechanism with an increased pressure in the pleural space, resulting into a mediastinal shift and cardiopulmonary dysfunction. So we can classify it into spontaneous one and traumatic ones. Spontaneous then can be divided into primary or secondary. Secondary, there's an underlying pulmonary disease, and trauma can either be done by us or as a result of a blunt or penetrating thorax trauma. So my first question to you, fellow residents, is what is the typical patient profile for a primary spontaneous pneumothorax?
Would it be like a young male?
Tall, thin, young male, probably a smoker. It would help.
That's correct. So we describe them as a patient as a male. He's around 10 to 30 years old. He's tall, he's thin, and he's smoking. And smoking up to 20 cigarettes a day increases the likelihood of 100 times. And smoking cannabis increases it even more. So for a secondary spontaneous pneumothorax, as I told you before, is a complication of an underlying pulmonary disease. And mostly it's a COPD in around 50 to 70% of the cases. And the pathogenesis is it's a rupture of subpleural blebs or bulla. These are small air-containing spaces, and due to the weakened lung tissue, they can rupture easily. In 4 to 3% of the cases, a cystic fibrosis, and there it's a rupture of cysts. And bear in mind that when the patient survives the 18th year, the incidence is increasing to 80 to 20% over their lifespan. Lung malignancy, it's more often seen in primary one than metastatic cases. And for necrotizing lung infections, it's, for example, bacterial pneumonia, it's a tuberculosis, or it can be a SARS-CoV infection. So the patient usually presents with a sudden onset of dyspnea, with a pleuritic chest pain, which means there's a sudden, a sharp, a burning, ipsilateral chest pain when inhaling or exhaling. And these patients also are anxious, or sometimes they have no symptoms at all. And this is especially true for a primary spontaneous pneumothorax. On the thistle examination, due to the missing lung tissue below the chest wall, we can hear an absence of breath sounds, a reduced ipsilateral chest expansion, or a hyperresonant percussion. For diagnostic imaging tools, we have the chest radiograaph. It's considered the gold standard. It's good for quantifying the size, to make the diagnosis, or to monitor the disease, mostly done in stable conditions. If it's getting a little bit more complicated, then we're going to decide for a CT scan, or when we suspect an underlying pulmonary disease, if you require surgery for planning. And another good tool is the ultrasound, because it can make the diagnosis of a pneumothorax. On the other side, it kind of quantify the size of it. but it can be helpful for guided procedures such as thoracentesis or a biopsy. And it's really good at measuring liquids. So if there's concomitant blood or if there's fluid, it can be helpful in the critical intubation, do it to the quick and bedside characterization of the tool. And there's the lung point sign. This is the 100% specific for a pneumothorax, where we can see on one side the pleura is gliding and the other one an absence of pleura gliding, indicating diversion of the parietal and the visceral pleura. So in the case of a management of a secondary spontaneous pneumothorax, almost all cases we need supplemental oxygen, we need a chest drain, a definitive management. I will come to that later on a little bit more in detail. And we had to treat the underlying pulmonary disease. In case of a primary spontaneous pneumothorax, the management depends on the symptoms, the ability to carry out daily activities and the patient's preference, and also the size of it. Usually the symptoms and the size correlates. In case of a first event, a small pneumothorax is considered below 3 centimeters, measured from the apex towards the lung parenchyma. And usually in these cases, observation and or supplemental oxygen is enough. In more larger cases, it's above 3 centimeters measured at the apex. You have to go for something like an aspiration with a cannula or for a needle, or more ongoing procedure such as a chest drain. What are the indications for a definitive management? So as I told you before, for a secondary spontaneous pneumothorax, in almost all of the cases we need a definitive therapy, and preferably during the same hospitalization. And for a primary one, we have indicators such as a prior history of a pneumothorax, so a recurrent disease. We have a grade size of the pneumothorax. If there are high-risk professions, such as airline pilots or divers, if there's a high burden of cyst, if there's an ongoing prolonged air leak, which means we can measure or can see the leak in the chest drain, if the patient wishes to do so, and if there are other indications for thoracoscopy. If we answer one of these questions with yes, we have to ask ourselves if the patient is a surgical candidate. Because the reason is, so we know today surgical pleurodesis has a higher efficacy and is therefore more beneficial than medical pleurodesis. And in general, pleurodesis means the apposition of the parietal and the visceral pleura in order to eliminate the pleural space. That can either be done partially or completely. And usually we do this during thoracoscopy. So for example, with a mechanical abrasion, so we use a dry gauze, we use a sponge, and we partially remove the parietal pleura at the apex region, or we insufflate chemical agents, sclerotic agents, such as tetracycline or grated talc. We can also eliminate risk factors by a blebectomy or a bullectomy, or for example, in more extensive disease, we can perform pleurectomy, which means the removal of the parietal and the visceral pleura, mostly done in malignant cases. Medical pleurodesis is performed if we have a clear contraindication for surgery, and it usually means that we insufflate these sclerotic agents over a chest tube. Bear in mind that in general, all of these procedures can cause a post-pleurodesis pain. This is an ongoing pain from neuropathic character for 2 weeks, and it's usually undertreated by us. So there's a picture of the apical bulla, which then will be resected, for example, with a stapler, which was done in this time. So we can see the stapler line on the right side of the picture. Another technique is a mechanical abrasion, where we use a sponge and we remove the parietal pleura in the apex region, causing a heavy inflammation process and then the apposition of these 2 layers. Bear in mind that any non-steroidal anti-inflammatory drugs can reduce the inflammatory process and therefore reduce the outcome. So the reason why we have to perform definitive therapy is that the likelihood of recurrence is very high. In case of a primary spontaneous pneumothorax, after a first event, we say it's around 30%. After a second event, it's 60%. And after the third event, it's even 90%. Therefore, we have to perform a definitive management. And we know today from the literature that the combination of different techniques has the highest success rate. For example, a talc pouch with a thoracoscopy and a surgical treatment of lung lesions can result in a below 2% recurrence rate, even with a long follow-up. Usually, or quite frequently, mechanical abrasion is performed in this department, and it can achieve around 3% recurrence rate, even with a longer follow-up. So, in case for a traumatic pneumothorax, it can be divided into non-iatrogenic and iatrogenic, as I told you before. Normally, non-iatrogenomy is a result of a blunt or penetrating thorax trauma. It can cause rib fractures, it can cause hemothorax, and usually in these cases, larger tubes are needed or necessary. In iatrogenic cases, it's usually the cause or the result of a central line or a thoracentesis or a barotrauma due to mechanical ventilation. Bear in mind that iatrogenic pneumothorax can be treated as a primary one, as a rule of thumb. Then there's something like tension. And tension pneumothorax means there's an extensive pressure inside of the pleural space, resulting in mediastinal shift and cardiopulmonary dysfunction. And this is usually a clinical diagnosis and not a radiological one. So a patient presents with severe dyspnea, tachycardia, and hypertension, and this needs to be decompressed rather quickly. There's an example where you can see a large pneumothorax on the right side of the chest, resulting in a mediastinal shift towards the left side. And on the other side, after drainage, you can clearly see the problem has been resolved. So how do we place these chest drains? So there are two famous spots, and one of them is called the position of Monaldi. It's in the second intercostal space in the medioclavicular line. And the second one is the position of Bülow. It's between the fourth and fifth intercostal space in the anterior medioaxillary line. And more recent guidelines suggest a triangle of safety, where we know today that at this area, the damage of underlying vascular structure is minimized. So therefore, we define this triangle as the base of the axilla on the top. On the posterior line is the lateral edge of the latissimus dorsi. On the inferior line is the fifth intercostal space. And on the anterior, it's the lateral edge of the pectoralis major. So then we use a technique to insert the drain. It's called the blunt dissection technique. So we usually can perform this technique with local anesthesia. We choose our intercostal space, and then we make an incision around 2 to 3 centimeters, 1 or 2 interspaces below the one where we want to go in. And that's the reason is we want to create a tunnel. So then when we remove the drain, there is some tissue left that can seal the leak. So we incisize around 2 or 3 centimeters horizontally, parallelly on the ribs, and then we bluntly dissect the underlying tissue, either with scissors, for example, or with our fingers. And then the last layer we're going to dissect with our fingers. It's called then digital exploration, and look for any adhesions in the next region. If there's a really large pneumothorax, then normally this procedure is not necessary. Then for insertion, we usually can use a sponge forceps, and bear in mind that for a pneumothorax, so air goes up inside the thoracic cavity, we have to put the drain apically, and if there's also blood or fluid, we have to put it more posteriorly. With a correct suture, we can seal the wound and also fix the drain, and the procedure is done. So I also brought here a case study from a person who underwent surgery at this department. It was a 75-year-old man who underwent a hepatic resection. This is usually done a chest radiograph after surgery to identify the correct position of the central line and the absence of a pneumothorax, which was done in this time. And then 2 days after, he developed severe dyspnea, pain on the left chest, palpitations, and tachycardia. Therefore, we have decided to go for another chest X-ray, and we could see in the first picture a large pneumothorax on the left side with an, and therefore decided to go for a chest drain in order to eliminate the problem, which has then been done. And unfortunately, on the 5th day, everything was luckily everything was fine. We made another chest X-ray in order to prove the full expansion of the lungs, which we have been done. And then we wanted to remove the drain afterwards. And then, unfortunately, the patient developed the symptoms again, so dyspnea, tachycardia, palpitations, and we could clearly prove the recurrence of the disease. And then, according to the guidelines, we have called the thoracic surgeon for advice, and he decided to go for a CT scan. That's what we could see during the CT scan. I'll try to describe it. So we could see a large subcutaneous emphysema and a recurrent pneumothorax with a suggestion of a fistula from the subcutaneous tissue towards the pleural space. And we suggested there was a bronchopleural fistula, so an ongoing leak from the damaged tissue. And therefore, I have to ask the question, what could be the next therapeutic approach? And bear in mind that this is treated like a primary spontaneous pneumothorax.
I think I would go for thoracoscopic exploration because there is suggested that there is a fistula. So I would go for surgery.
Thank you very much. That's a good idea, and you can or argue which one would be the correct choice. So according to guidelines now, a definitive management is indicated. So we have to ask whether this patient is a surgical candidate. In this case, he was one. So we have decided to go for thoracoscopy. That should normally prove an underwater leak test. So we have a view inside of the pleural space. On the inferior edge, we can see the pulmonary tissue, and on the upper edge, we can see the end of the chest wall. And what we like to prove is some bubbles going out from the lung parenchyma. So we tell the anesthesiologist to inflate or ventilate the lung on the right, in this case on the left side. And when we can measure or can see some bubbles rising up from the water, this is proof of an underwater leak test. And in this case, it was the case. So then we have decided to resect the damaged tissue. And this was done with a stapler. And the stapler seals the pulmonary tissue and the leak. And afterwards, the patient was fine. Thank you very much for your attention.
Yeah, Valerian, thank you very much. Excellent presentation. Even though it's a common thing, I did learn a few things here. So thank you very much. This is a very frequent problem. So I think that every surgeon needs to know how to handle that, what he can do himself, and when he has to call for help in this situation. Maybe, so thank you, Dr. Hillinger, for being with us today. Maybe one small question for us. When we do abdominal surgery, liver surgery, is not uncommon that we have a hole in the diaphragm, either for tumors. And we treat that in a very basic way. We put the suction, we take the air, and we do a stitch around that and do an X-ray. Is that correct? And how long should we follow these cases if there are no other risk factor except the hole that we've recognized and we can suture it?
Well, basically the hole or the pneumothorax gets resorbed usually. So we also try to avoid more and more the chest tubes even after lung resections if the lung itself is quite healthy and there's just a local problem. So maybe it's not even necessary to put a chest tube. It's just for our own safety, and especially under ventilation, you want to be sure. But basically, if you pull the chest tube the next day, that's it. If you didn't injure the lung, it's not necessary to keep it longer. And if there is also no effusion, of course.
Thanks for the nice presentation. I would have just one question, maybe for Dr. Hillinger. When we have this pneumothorax 3 centimeters, 4 centimeters, we do not put any drains. How you always recommend to give oxygen, and how often will they resolve just by giving oxygen?
Yeah, well, actually, you should give quite a lot of oxygen to overcome the partial pressure inside the chest cavity. So it has not to be like 2 liters, it has to be like 8 to 10 liters, which is not healthy always. So we basically just observe. And it really depends on the symptoms of the patient and also on the time frame. For instance, if a young patient comes after 1 week, of a pneumothorax, the symptoms 1 week ago, it's probably not even necessary to observe the next day or do another chest X-ray the next day, but maybe after another week. So the oxygen is, I think, more or less psychological.
I have another question. Thank you very much. Very nice talk. You said pleurectomy, and then you said visceral and pleural, parietal. Sorry. So when would you do visceral? You said that. I'm not sure you meant it.
I didn't get that part, but it's usually parietal. Yes. Yeah. Except you have a mesothelioma, then it's different. Okay. So thank you very much. Thank you.